For this video, we will be focused on attention deficit hyperactivity disorder and the pharmacologic agents indicated for ADHD. So ADHD can be broken down into two types, the inattentive type and the hyperactive type, or can be a combined presentation. So I will not really focus on the criteria for diagnosis of either type because this will be covered in your IQ discussion. But keep in mind there are different presentations, which hints that just like many of the other psychiatric conditions we have discussed in previous videos, ADHD also has etiological heterogeneity and an unclear pathophys that likely includes dysfunctional and unbalanced neurotransmitters that varies amongst the patients. So the primary neurotransmitters dysregulated in ADHD are thought to be dopamine and norepinephrine. For example, changes in dopamine transporters that lead to increased reuptake, for example, or dopamine receptors that lead to reduced sensitivity of the receptors have been reported in ADHD patients and are thought to lead to deficient dopamine signaling. We know that dopamine helps regulate learning, motivation, memory, and behaviors, and norepinephrine helps to regulate alertness and attention. So dysregulation of dopamine and norepinephrine signaling that occurs in ADHD leads to the inattentive and hyperactive symptoms needed for diagnosis. Now, if we can modulate dopamine and norepinephrine signaling with pharmacologic treatments, we can improve executive function, sustain attention, regulate activity and behaviors. So now that we understand which neurotransmitter systems we need to modulate, let's talk about the agents we have available to do so. So moving to our next slide. Now we're going to start off this discussion by going over our stimulants that are used for the treatment of ADHD, which are the stereotypical ADHD treatments most think of. So stimulants can be categorized into two types. We have our methylphenidate agents and our amphetamine agents. So we'll start off with our amphetamines, which includes dextroamphetamine and amphetamine salt combinations like Adderall. We have our dextroamphetamine alone, or we have our prodrug, which is lisdexamphetamine like Vyvanse. So the beneficial mechanism of action of these agents includes a number of steps. The first one, thought to be one of its primary effects, is through competitive inhibition of our dopamine transporters, preventing that dopamine reuptake. So it remains in the synapse for longer to interact with various receptors to correct that deficiency, if present, and modulate neurotransmitter signaling to correct imbalances. Now, this effect is competitive, and these transporters can actually reverse transport amphetamines into the presynaptic terminals, and then these amphetamines will then interfere with vesicular monoamine transporters and vesicular pH because these are weak bases, and this will prevent dopamine-loaded vesicle formation. So more dopamine is in the cytosol. Now, amphetamines also promote dopamine transporter changes that actually lead to the dopamine being effluxed into the synapse so that that cytosolic dopamine can be used and pushed into that synapse. So overall, a number of dopamine modulatory effects promoting more dopamine signaling. So as for norepinephrine, amphetamines are thought to analogously affect norepinephrine signaling. Through a very similar mechanism as we just described for dopamine. So now a few pharmacologic considerations specific to our amphetamine. So because this agent is a weak base and a good portion is renally cleared, unchanged in the urine, urinary pH can greatly affect clearance of these drugs. So for the remaining portion that does undergo hepatic metabolism, this will be through CYP2D6, which is one of the enzymes responsible for metabolite generation. So we're going to need to worry about pharmacogenetics there. And then drug-drug interactions can come into play for both these renal and hepatic elimination mechanisms. And then lastly, for Vyvanse, which is our prodrug, this actually undergoes bioactivation through hydrolytic activity of red blood cells to dextroamphetamine to then go and have its effects, which is thought to reduce abuse potential, which we will talk about in just a minute. So now moving on to our next agents, which will include methylphenidate, which you might know as Concerta, and dexmethylphenidate, which you might know as Fauquelin. And these agents share a similar mechanism of action with the amphetamines in that they will also inhibit dopamine and norepinephrine reuptake transporters, modulating neurotransmitter systems to restore balance in ADHD. However, they're not going to promote neurotransmitter release like the other mechanisms we talked about for the amphetamines. So these agents also differ in that they are metabolized via non-CYP mechanisms, and these metabolites are renally cleared. Now, as for ADRs, you can probably guess a number of them just based off of this increase in dopamine and norepinephrine levels. And these will be very similar for both groups of agents. So there are going to be a number of cardiovascular concerns to be aware of for these agents, like tachycardia, hypertension, arrhythmia, etc. And there can also be vasoconstriction of the peripheral vasculature, leading to things like Raynaud's phenomenon, for example. These can induce mania. They also lower the seizure threshold. And with chronic use and depending upon patient age, these can also impact growth. So other ADRs include things like tics, insomnia, weight loss, as well as decreased appetite and rebound hyperactivity. Now, some of these ADRs can be managed with dosing changes or formulation changes or even drug holidays. And keep in mind that this is possible because many of these agents come in a number of strengths. They come in immediate release, extended release, or even more complex release systems to help balance that efficacy and the ADRs. And then lastly, we need to just touch on the fact that these agents are controlled substance that fall into the Schedule II class, meaning that they have the highest potential for misuse among prescription agents, which may lead to severe psychological and physical dependence. So because of this, there are many laws in place to regulate prescribing and dispensing of these medications. So now that we've addressed our psychostimulants, which are considered our first-line agents for ADHD treatment, what are our other options for those unable to take or tolerate these agents for whatever reason? So moving on to our next slide. Now, moving on from our psychostimulants to our other agents, we will start off with our selective norepinephrine reuptake inhibitors like atomoxetine and viloxazine, which will inhibit norepinephrine reuptake, leading to more norepinephrine remaining in the synapse to correct any deficiency if present, and then over time modulate norepinephrine signaling to more balanced levels. And then another thing to note, in the prefrontal cortex, the amount of dopamine reuptake transporters is actually much less than other brain regions. So in this particular region, norepinephrine reuptake transporters actually help with dopamine reuptake. So these agents are also going to increase dopamine levels in the synapse as well. So these agents are an option for those that would like to avoid stimulants or as a second-line agent for those unable to tolerate or those that do not respond to stimulants. And as for pharmacokinetic consideration, these agents can be metabolized by CYP2D6. So same concerns as the amphetamines with those drug-drug interactions. And as you might expect with ADRs, these are going to be very similar to the psychostimulants because of the norepinephrine modulating effects. So we're still going to have cardiovascular concerns, mania, psychosis, growth delay, insomnia, decreased appetite and weight loss, as well as agitation. There is also going to be a risk of suicidal ideation with these agents because of their antidepressant effects, as well as sexual dysfunction. Now, keep in mind, antidepressants like bupropion will alter similar neurotransmitter systems, and though not approved for ADHD indications, these can be second-line agents or add-ons for those with comorbid depression or other psychiatric conditions that may benefit. Now, our last two agents that we're going to discuss on this slide will be clonidine and guanfacine, which are both alpha-2 agonists. And these agents are typically used as adjuncts to help address specific symptoms like aggression, or to address specific adverse effects of stimulants like insomnia or tics. But these can also just be a second-line option as well for ADHD. And as you'd expect, these agents will agonize those alpha-2 receptors on the presynaptic side to act as that off switch on neurotransmitter release. For example, to counteract too much stimulant effect, or on the postsynaptic side, to lead to inhibitory inputs on signal propagation to also dampen stimulant effects when it is too much. Now, as we discussed back in cardio, these agents can peripherally lead to hypotension, bradycardia, and syncope. So starting low and titrating slow will be needed, and they will have to be tapered off if they need to be discontinued for whatever reason. Moving to our summary slide. This finishes up our discussion of agents you may see used to treat ADHD. So we've addressed both mechanism of action and important pharmacologic considerations for each agent or group of agents, and it will be important for you to become familiar with these options so that you can communicate these to varying age groups, because I'm sure you can imagine situations where you may need to adjust your counseling techniques to lay out the options and set realistic expectations. For example, a parent with a 5-year-old child diagnosed with ADHD versus a parent and a 15-year-old patient with ADHD, or an adult patient that is diagnosed with ADHD. And it will be important to consider which characteristics might be of most importance for which patients, like growth delay versus sexual dysfunction versus abuse potential. So again, try to work through ADHD pharmacology in different patient contexts.